My name is Nene Diallo. I am the Director of Health for Africare. I was a pediatrician by training. I worked in Guinea for 8 years as a pediatrician in a teaching hospital, where I was confronted with high levels of mortality, infant mortality, due to preventable diseases like measles, malaria, diarrhea, etc. So I realized how, little a medical doctor can do, in terms of reducing mortality in a developing country, Africa in particular. So that motivated me after 8 years to seek a degree in public health. So I came to the US and went to San Diego State University, where I got my MPH in '94, with concentration in maternal and child health. And then I went back home, couldn't find a job in public health, came back, found something in domestic public health, worked for the Virginia Department of Health for 8 years in HIV surveillance. But all along, I knew, my expertise is in international health. So when I saw an opportunity with Africare in 2007, I applied and was accepted as a technical specialist. From there, I became a deputy director in 2013 and a director recently. When I joined Africare in 2007, I was really, I fell in love with public health. Because again, when I compared what a physician does in an office in Africa, and I saw what Africare was doing in rural areas, hard to reach communities in Africa, I was very, impressed. Africare was created by, Peace Corps volunteers, returning Peace Corps volunteers. So everything Africare does is really mirroring, what Peace Corps volunteers do. The farthest village you can imagine, that's where you find Africare. We are known for what we do at the community level, training lay people, to treat, simple cases or to refer complicated cases, linking communities to health facilities, using local, people and local solutions, for sustainability. The task shifting is relatively new, but that's what Africare has been doing for 45 years. The challenges are when you go to these communities, the needs are so huge, but you are limited. Often you have money for one disease, you have funding for malaria, you are funding for nutrition or something like that. We respond to RFAs most of the time, very prescriptive. So you wish you could do more, but you are limited. Equity is an issue, making sure the poorest of the poor is reached, whether it's in rural communities or they have moved to urban areas. I think there is a need to evolve, follow the neediest community, populations where they live. And there is a need for more integration instead of parallel, vertical, programs. This is just money for malaria, this is just money for HIV, to have a comprehensive approach to the needs of these communities. What is inspiring about this job is seeing the difference in the field. It's realizing that progress is being made. You can see progress. You can see that malaria is no longer causing as much, death and disease as it used to be. Complicated malaria cases are rare. The prevention with bed nets is working. Infant mortality has decreased. Maternal mortality is decreasing. So it's really, seeing that and witnessing that. Years ago I visited a village in Senegal, and talking with the village chief, he told me, he said, I don't know, whatever you all are doing in our communities, it's working. because our village is, getting very crowded. Children used to die when I was young. Now the village is really getting crowded. So for him, he doesn't need, more to tell that whatever, projects are doing in his village, it's working. So that's really, it gives you a meaning to what you are doing. You see progress on a daily basis. It's really all about trying to make a difference. I saw what a medical doctor can do. I realized how important prevention is in public health in general.